Welcome to The Explainer. Today we're diving deep into carbapenems. This is a class of antibiotics that, in many ways, represents the last line of defense in the hospital. They are a true cornerstone of modern medicine, and understanding their power, their place, and, frankly, their peril is absolutely crucial.
This statement really says it all, doesn't it? We're not just talking about any old antibiotic. We're talking about the drugs we reach for when other options have failed. So you can be sure that whenever a carbapenem is being considered, the stakes are almost always incredibly high.
All right, here's our game plan. First, we'll explore why these drugs are such a cornerstone of therapy. Then, we'll get into the nitty-gritty of administration, especially in special populations. After that, we have to talk about the risks and the growing specter of resistance. That leads us to the critical need for stewardship, and we'll wrap it all up by testing your knowledge.
Okay, let's jump right into Section 1, a cornerstone of therapy. We need to understand what makes these drugs so uniquely powerful and exactly where they fit in our modern therapeutic toolbox.
So what are these things really? At their core, carbapenems are beta-lactams, which means they work by attacking the bacterial cell wall. But here's their claim to fame, a very broad spectrum. That's the source of all their power. It means they can take out a huge range of bacteria, including many that have become resistant to other drugs. But, as we'll see, that strength is also their greatest liability.
So when do we actually reach for them? Well, it's a short and very serious list. We're talking about infections from multi-resistant gram-negative rods. You know, the really tough bugs. Things like nasty Acinetobacter infections, or Pseudomonas that's resistant to everything else. You'll also see them used in truly dire situations, like infected necrotic pancreatitis or flesh-eating bacteria. The common thread here? It's always severity and resistance.
Let's make this real for a second. Picture this. A patient has just come out of a complex neurosurgery. But post-op, they develop bacterial meningitis. And to make matters worse, they have a drain in place going right into their cerebral spinal fluid. This is about as serious as it gets.
So in this exact situation, what's the move? Very often, the go-to is a carbapenem, like Meropenem, used all by itself. And the thinking is crystal clear. First, it has fantastic penetration into the central nervous system, so it can actually get to the infection. And second, its broad coverage is likely to hit whatever bug is causing the problem.
So knowing why to use these drugs is one thing. Now we need to cover how to use them. Let's move on to Section 2, administration, where we'll look at dosing and some really important considerations for our most vulnerable patients.
If you look at the standard adult dosages, you immediately start to see the clinical trade-offs. You've got Meropenem and Imipenem, which need to be given multiple times a day but give you that super broad coverage. And then you have Ertapenem, which is incredibly convenient, just once a day, but it comes at a price. It has a narrower spectrum, and notably, it doesn't cover tough bugs like Pseudomonas or Acinetobacter.
But remember that case of meningitis or a really nasty Pseudomonas infection? The standard dose just isn't going to cut it. In those cases, the dose of Meropenem is doubled. We're talking 2 grams 3 times a day. You need that aggressive dosing to really hammer the infection and get enough drug where it needs to be. And what about our youngest patients? For kids and even neonates, Meropenem is strictly a reserve option. It is absolutely not a first choice. Its use is restricted to those nightmare scenarios where you've got a resistant bug causing meningitis. It just reinforces how carefully we have to guard these last resort drugs. Okay, with all this power comes some pretty serious risk. So Section 3 is all about weighing those inherent risks. What's the potential cost of using such a potent weapon? One of the biggest concerns is collateral damage. Because carbapenems are so broad, they don't just kill the bad guys. They wipe out huge populations of the good bacteria in our gut. This creates a vacuum, a perfect opportunity for opportunistic pathogens like C. difficile to move in, take over, and cause a whole new, serious infection.
Now, a question that always comes up is what do you do with a patient who has a penicillin allergy? And this is where you have to be really precise. If a patient had a severe, immediate, life-threatening reaction to penicillin, we're talking anaphylaxis, you have to stop and proceed with extreme caution. likely consulting an allergy protocol. But for other, less severe reactions, like a simple rash, carbapenems can often be used safely. That's because their chemical side chains are different enough.
This all leads us to the most urgent threat. Really, the climax of this whole story. The specter of resistance. This isn't just a theoretical problem. It's a global crisis that threatens the future of these incredibly important drugs.
So how do bacteria fight back? Well, their main weapon is an enzyme called a carbapenemase. The easiest way to think about it is like a molecular pair of scissors. The bacteria produces this enzyme, it finds the carbapenemase antibiotic molecule, and it just snips it in half, rendering it completely useless. The drug is neutralized before it even has a chance to work.
You've probably started seeing these names pop up on lab reports. NDM, KPC, OXA48. Think of these as the most wanted list of resistance enzymes spreading around the globe. And that's not all. Bacteria have other tricks up their sleeves, like changing the doorways into their cell so the drug can't get in, or using tiny pumps to spit it right back out.
This right here is the critical point. Even if a lab test says a bug is sensitive to a carbapenem, if you know it's producing one of these carbapenemase enzymes, using that drug is a huge gamble. This analogy just nails it. Yeah, the car can technically go 200 miles an hour, but with bald tires and a loose steering wheel, a catastrophic failure is just waiting to happen. Are you willing to take that chance? So, faced with this looming threat, what's the right move? What's the responsible path forward? Well, that brings us to our resolution. The Stewardship Imperative. We have to protect these drugs. And the absolute core principle of stewardship is something called de-escalation. It works like this. When a patient is critically ill, you might have to start with a big gun like Meropenem because you don't know exactly what you're fighting. But the second a lab calls with culture results, the moment you identify the culprit and know exactly what kills it, you have an obligation to switch. You pull back to the narrowest, most targeted antibiotic that will do the job. Okay, we have covered a ton of ground: the power, the risks, the resistance, and our responsibility. So let's shift gears and test that knowledge to see how these key concepts apply in practice.
First question. Let's go back to our case, the patient with suspected meningitis right after neurosurgery. Which carbapenems is the usual recommendation in that scenario?
And the answer is C, Meropenem. Remember, that's the one we choose for its excellent ability to get into the central nervous system. Question 2. Thinking with our stewardship hats on, what is a key disadvantage of using carbapenems? The answer is C. It's that double-edged sword we talked about. Their greatest strength, that incredibly broad spectrum, is also their greatest weakness because it drives the selection of even tougher multi-drug-resistant bacteria. And our final question. What is the primary group of bacteria that a carbapenem like Meropenem is really designed to target? And the answer is B, multi-resistant gram-negative rods. This brings us right back to where we started. Carbapenems are a powerful but ultimately finite resource. Using them wisely isn't just a good idea, it's a shared responsibility to make sure they're still around and still working for the next patient who desperately needs them. Thanks for joining The Explainer.